seen for quite a while. And I'll tell you who really makes me excited to be here today. Let me find it. Well, that's how excited I am.
Always when he's here.
Okay. Yvonne is here today, and she brought her lovely daughter, Melissa. So welcome. And for my IPF support group, I have quite a few here today as well. However, you also always come to lunch. But Bob Valentine today is here today, and I'm so glad that he made the journey down here to see us today. Let's see, who else brought somebody? Oh, Dennis Lord. Where are you, Dennis? His first PEP luncheon since he graduated, and he brought his lovely bride, Jennifer, with him. Okay, and somebody very special that I was excited to see is Harvey Atkins. Harvey, raise your hand. Harvey went to the program several years ago, and he went down to town. And he happened to be in town today doing some work on his rental here, because he moved back to Delaware. So it was exciting that he wanted to spend one of his days here with us. So that's pretty special. So welcome back. Anytime you're in town, you know where you live. This is always home for you.
Yeah, no doubt.
So welcome. It's so good to see you looking so well. He came into rehab in a wheelchair. Thank you. And now he is just an amazing man. So really great to see him back as well. And Calvin's here today. We haven't seen him for a while. He's on lunch last night. And who else is here that just won a prize? Mary Sheridan. Mary, welcome.
Thank you so much.
And you are
Kellen.
Kellen, welcome as well. And it's always great to see Betsy here. So Betsy, let's see, well, Mercedes, we haven't seen you for a while. So welcome back, Mercedes. And did I forget anybody? Oh, where? Cheryl. Hi, Cheryl. Good to see you back as well. This is one of my favorite days of the month is PEP Luncheon, because I get to spend it with all of you. You guys are my heroes because you work so hard to breathe every single day. And it's something that we all take for granted, that don't have lung issues. So, oh, wait a minute. Paul's back. Yeah. You know, if we don't see you in the gym, we call you. So I just left a message on his phone the other day. Where in the heck have you been? And all the ladies were asking about you in yoga. Where have you been? Has nothing to do with the leotard, but welcome back. It's good to have you back as well. Did I forget anybody? Okay. I think that's it that I have to say. Let's see. Our luncheon's late this month, so that means board meeting's next month, right? Next week. So things are going well. Remember, we have a costume party right before Halloween or around Halloween, so think of what you want to be in the gym, but you have to be able to see out of your mask so you don't fall on the treadmills, and then I don't have to fill out a lot of paperwork on that. So we're looking forward to that. Anything else, Joseph? We just got back from a seminar in Portland. We've never been to a AACVPR meeting before, and that's with a bunch of nurses. We always hang out with all the RTs. The nurses, they're wild. I had to work to keep up with these people.
Party.
And can they drink? So anyway, I think I'm going to go back to CSPR because that's more my speed of people. But it was great. We learned a lot of new things, and hopefully to share with you guys. We did test out a new POC, portable oxygen concentrator. And it's still not up to my standards, but it's better than any other one that's out there right now. So we're gonna have the guy come out and talk to us about it. And what we're looking for is battery life. And this one happened to have a better battery life than more of the, some of the other ones. And the purity of oxygen was higher,
And the bolus, it'll keep
And,
up with
yeah.
40 breaths a minute.
30 breaths per minute, so you can really go to town on that.
How long a battery life?
They're,
She liked it because she doesn't.
I don't
Longer
remember,
battery
but it was
life
longer
anyway.
than most of them, so it was really impressive. So as soon as, it
How high did it
was a little, it was less than 10
Oh,
pounds,
yeah, it's about. like
but
that.
it rolls on a cart, which is kind of nice.
What did it go to on continuous flow?
Only the tube.
Oh, okay.
Unfortunately, IPF and ILD people, it won't meet your needs for basic COPD. However, if we put an oximizer on it to get you 4, okay? So we gotta look out of the box here, guys. So it's really exciting that we saw some new things and we looked at the new steps and other pieces of equipment. So it was well worth flying all that distance to go to this seminar.
What a party, by the way.
And Joseph, they call him Hips now because all he does is dance. And when we were going to the airport, we were getting on the train to go to the airport and some lady walks up to him and Cynthia says, "Aren't you the dancers from Scott Care?" So now we call him Hips Moyer because he was just out there shaking a leg. I saw a new side of Joseph, but it was a wonderful, wonderful time. So thank you for letting us have that week off and have the luncheon on this week. We appreciate it. Anything else? Did I forget anything else? No? Okay. Jay, are you ready?
Yes.
So today our guest speaker, again, before we get into the whole guest speaker thing, turn off your cell phones or put them on vibrate, except for you. Secondly, no chit-chatting. And because all our guest speakers volunteer their time to be here with us today. So today we have Jay Unga, and he's going to do a lung transplant overview. Jay is a nurse from the UCLA Medical Center. He's a transplant coordinator. He's Sarah's coordinator. And we've seen him with many, many of our patients. They refer quite a few to us. So it's really nice to have him spend his day with us talking about lung transplants. Jay?
Jackie, I always look forward to this invite, so I think it's every, 2 years?
Every 2 years.
Yeah. So what I'm going to talk about is the overview of lung transplant. Lung transplant is reserved for people with end-stage lung diseases, most of you know. So just our UCLA lung program started back in the early 90s. Just a little, some of the notables in our faculty here. We have a new medical director. Our previous director has moved on to a different challenge in his life. So we have Dr. David Saya, who just took over in May or June this year. And Dr. Ross was previously our medical director. Some notables of our program, we're usually in the top 10 in terms of the volume of lung transplant in the country. This year we're currently at 76. We did a total of 80 last year, so we're way ahead of schedule. In 2016 we were the largest combined heart and lung program in the country, which was 170. Some of you may have heard about the Lung in the Box. This is the first organ care system in that's the first, or the first center to use this box, and I'll tell you more about it later on. It's how you preserve the organ on a trip back to the hospital. And we do perform multi-organ transplant. There's not many centers that do lung, liver, lung, kidney, heart, lung. So it's a special for the month for us. We're one of, like I said, we're one of the few centers. USC doesn't do multi-organ, so when they have somebody that needs a lung or liver, they're referred to us. So And then in 2016, we performed our 1,000th lung transplant. So these are the numbers that were mentioned to you. Like we're up to 76 currently. On the far left in the white, those are our statistics. The UNOS, the United Network for Organ Sharing, the government brand that's in charge of organ transplants. You as a program, as a center, are mandated to publish your statistics, your survival statistics, primarily 1 year and 3 years. Okay, so our 1 year, the bottom's the national outcome. It's about 89.55. Ours is 91.53, so it's a percent or two better. The 1 year, the 3 years, ours UCLA is 76.47, and nationally it's 73.13. So those are the two statistics that are given to the public. What's not there is a 5-year survival. Okay, it's about 55-60%. So that's why lung transplant is not offered to those unless you have less than 2 years to live. As you can see, the survival isn't all that great, but it is what it is, and a lot of people would choose that over, palliative care or hospice, because we do have patients who are 10, 15, 20 years out. So it's really a testament to the survival, the resiliency of the patients. How does a referral work? How does somebody get referred for a lung transplant? So this is the process where your pulmonologist calls us or sends us your records. We then review it to make sure that it's an appropriate referral, so we don't waste your time or the physician's time. And we have certain criteria where we determine who we will evaluate. So clinically, we look at your information and we think it's an appropriate evaluation. We then get financial verification from your insurance. We need to see what insurance you have to see if they're contracted with UCLA. UCLA, which is a state-run facility, right? Unfortunately, we don't accept Medi-Cal. So that's one of the only glitch in our program is we don't accept Medi-Cal. The contract for Medi-Cal goes to USC. So it's all above my pay grade. I can't tell you any more than that. So once somebody's financially cleared, we then schedule a visit, a consult visit with our pulmonologist. Right now we have 6 transplant pulmonologists, so you'll see one of them. And when you do come, actually before you come, we send you a PowerPoint presentation of our lung transplant program, how the evaluation works, the testing, the listing process, what happens when you get transplanted, etc. And so we go over that also with you when we see you for the first time. So these are just a list of tests. I'm not going to bore you guys to that, but it's just evaluation of the laboratory. The simple labs, actually not simple, it's kind of complicated labs, tests where we look at your HIV, hepatitis A, B, and C, all the other stuff, titers of viruses, whether or not you're exposed to it, like cytomegalovirus, Epstein-Barr. These are things that are somewhat irrelevant. Now more relevant after you're transplanted. And the usual tests we do to determine whether or not you're a candidate, number one is a CAT scan of your chest. We want to make sure what the doctor diagnosed you with is what you have. We do an ultrasound of your carotids to make sure that there's no narrowing. If there is, we need to quantify the narrowing of your carotids. We do an ultrasound of your diaphragm. Your diaphragm's right here, so when you breathe or sniff, that thing should move up. Okay, if it doesn't move up, then why doesn't it? So was there trauma? Was there some previous surgery? Was there an accident? So those are things we want to know. Because if you have a weak or paralyzed diaphragm, we cannot transplant that side. Okay. And cardiac workup, we do an ultrasound of your heart, we do an EKG. One of the only invasive tests that we do is the right and left angiogram. And that's an outpatient procedure. Has anybody here ever had an angiogram? Yes, okay. So basically is they could either go through your groin area or your wrist. They insert a tiny catheter, it measures the pressure in your heart. And also they go through the left side of the heart where they inject a dye and it paints a beautiful picture of your arteries that surrounds your heart. So we want to know whether or not your heart can survive the lung transplant, okay? And then the next one is the perfusion scan. We want to know what percentage perfusion is being done by your right lung and your left lung. So a lot of patients who are single lung candidates, that's what we want to know, because and I'll show you more later who's a single lung candidate, who's a double lung candidate. So perfusion will tell us to quantify your right lung versus left lung flow. And the last part of the evaluation is you get to meet the surgeon. We have 3 surgeons right now. We had 4. Dr. Hunter had moved to Utah. So we have 3 surgeons right now, and they are busy. They're cranking surgeries left and right. So, so you do meet the surgeon. You do see a psychiatrist. You see a pharmacist, a social worker. What else? Yeah, nutritionist. So all these people see you, and then the day after, we present you the selection committee. So the selection committee is a multidisciplinary group. There's about 20-25 people, about the size, maybe half the size of this room. It's about 20-25 people, and the pulmonologist who you saw will present your case. This is so-and-so, he's got this disease, this is what a CAT scan looks like, and everybody who you saw will comment on their interaction with you. And at that point, we'll determine whether or not somebody is a suitable candidate. If they are, is it a single lung? Is it a double lung? Whether either left, either right, mandatory left. So all those things are discussed. And on the screen is the exclusion and the inclusion criteria. Who's a candidate and who's not a candidate. So for the exclusion criteria, just to see there, if you have any recent malignancy, okay, if you have a history of cancer with less than 5 years, you're not a candidate until after that 5-year marker. Morbid obesity or cachexia, or the opposite. Any other end organ failure, if you're still having substance addiction, lack of social support, lack of rehab potential. That's why this facility is so important about doing rehab, because we want to make sure patients will survive and thrive after the surgery. And also pan-resistant organisms. If you're growing bugs that are resistant to antibiotics, so those are the issues. And the inclusion criteria. So end-stage lung disease, risk of death within 2 years. Basically, disease that are inadequate response to conventional treatment, O2 dependency, and PFT consistent with end-stage lung disease. So those are the inclusion criteria. Age, single versus double lung criteria. So 18 to 60, we would offer an automatic double lung. 61 to 70, depends on how much lung disease you have, and also all the clinical data, either single or double. And then over 70, it's a single lung. And then right there, concomitant procedures. That means if you have other issues that may increase your risk. For example, we are one of the few transplant programs in the West Coast that will do, if you have coronary disease or a valve that's bad that needs to be repaired, we can do that at the time of surgery, okay? We're one of the few centers that do that. We get referrals from San Francisco, San Diego, USC, Cedars. So, because those patients, if they're seen there, that, for example, if they need to have a bypass at the time, and they also need a lung transplant, oftentimes they will be denied at that facility, and then they're referred to UCLA. Hey, yes, Kelvin.
That's what happened to me.
See, Kelvin's a walking example. So we're proud to say our surgeons are so technically sound that they can do this, and that's one of the things that we offer. So it's very common that we get referrals from Washington, even Kaiser, Colorado. Kaiser, Colorado, we get a lot of patients from them. So yeah. Any questions so far?
Yeah, I guess I do.
Yes,
I
Mary.
don't even know what question to ask, but that age 70, is it due to studies and outcome?
Yes.
So long?
It's based on historical data in terms of experiences. So we've done somebody as old as 79 in the past. In the 13 years I've been there, we've done somebody that's 79. I think after that, 75 is our next youngest. Okay, how does the list work? When somebody's deemed a candidate for lung transplant, how does the list work? The list works by every patient who are listed, they get a lung allocation score, or we call it LAS. And that is based on how sick the person is and what their urgency and survival, post-transplant. The median score in the country is about 36. Okay, so 36. So the higher the score, the sicker the patient. So we have 4 blood types: A, O, the most common; B and AB are the less common. So when I put patients on the list, I let them know what their score is, and usually they're placed on the UCLA's transplant list. Currently, we have about 50 patients on the list. I think the majority of that is O, then A, then B and AB are the maybe 1 or 2 people. So that score is based on how sick they are. Their pulmonary function tests, how much oxygen they're using at rest, what their blood gas numbers are, what the distance on the 6-minute walk study, what the pressure is in their heart when they had the angiogram done. So all those things we enter all that data into the UNOS computer, and then it spits out a score based on all that information. And aside from that, we also have to look at the size. Size matters here. So when somebody, let's say, who's 5'9" that gets listed, we usually put in their donor height range. And that donor height range is usually +3, -3 inches of the recipient's height. Because we can't shove a 6-foot donor into a 5-foot recipient, right? It'll be sticking out. There's also, right there you see antibody sensitization. That's basically what happens is if a person gets exposed to, let's say, women from childbirth, okay, pregnancies, or blood transfusions, sometimes you develop antibodies within your bloodstream, and that can affect the amount of your donor pool that you can get. So that can affect that as well. And then when we list patients, like I said, double lung, either lung, preferred right, preferred left, or mandatory right, mandatory left, all depending on, remember I mentioned to you the ultrasound diaphragm. Somebody's got a paralyzed diaphragm, we don't like to touch that area. And the waiting time can vary, okay? It can happen in a week, 3 weeks, 3 months, 6 months. And if you have a low score, that you may wait longer, a year to 2 years, all depends. The goal of the list, the computation, the UNOS calculator, is to transplant those who are in dire need of a transplant. Okay. Right now we have patients who are in the 60s, 70s, the LAS, that are in the hospital waiting. So a lot of times because of their size, it's very difficult to find a donor. While somebody's on the list, we will see them every 2 to 3 months or sooner to make sure that the lung allocation score actually reflects how sick they are. For example, if we listed somebody with a score of 40, and then 2 weeks later they call me saying, Jay, I'm using more oxygen to keep my saturation above 90, So we tell them, come on in, we'll do all the testing, like the breathing test, the blood gas. Of course, that'll show worse numbers, therefore giving them a higher score. Questions so far?
What's your cutoff
Yes?
for the age? Is there a cutoff for the age?
That's a very good question. It's all based, usually early 70s. We're talking about that. It's all based on the overall clinical status of the patient. Like I said, the oldest one we did within the last 13 years I did, it was 79. Then go back was 75. Yeah, so those are the two oldest.
That's the official word, but I was told by the doctor that it was 75 that he got up.
Well, we just talked about that as a program. We don't have a concrete number. That's why it's based on the clinical overall condition. If somebody's got diabetes and all the other comorbidities and risk factors, so that may be younger than, I would just say less than 75. So anyway, what happens? Oh yes.
How long did the oldest patients that got the transplant, how long did they survive?
You know, less than a year, unfortunately, because with age comes complications. So that's why it's all a risk, weighing the risk and benefit of transplant. Yes?
For the single lung transplant, when you have a viable organ, can that set of lungs be then helping two people?
Correct. If you have one healthy donor and you have two single lung recipients waiting, we often do that. Was that your question? Yeah. So they become sisters or brothers forever, those two recipients. Yes?
I read recently about a lung transplant that was from the donor was a fellow who had drowned. I can't comprehend that.
Yeah, the drowning usually all depends. Usually when somebody drowns and you got foreign objects like the blood, the water and seawater. Yeah, I don't know how that can work. So yeah, usually we don't do drowning. Yeah. Yes.
If a person has AV blood, do they have to have a donor with the same?
They are the universal recipient. They can get from anybody and everybody. But oftentimes when they cross like an O blood type goes to an AB, usually that O donor has to be offered to all the O recipients. So more than likely, when an O is offered to the AB, oftentimes the quality of that O is not good. So that's why all the O recipients have declined it. So this is the call. This is one of the things that somebody else raised their hand? Go ahead.
Okay, so when you do have all those tests done, how long are they good for?
You know, they're mostly good for, I would say, 2 years.
Okay.
It all depends on, let's say if you had an angiogram, it was sparkling clean, right? So that may hold longer than something that, let's say you had a 50% blockage in one of your arteries. So it all depends, but for the most part, they're good for a couple of years. Yes?
The number of people on the list was 50 or 15?
About 50, 50.
50.
And that fluctuates. So, but it stays around there. When we transplant somebody, I add another one. So, but that's consistent over the last 2-3 years. The call is one of the most favorite things that I love to do when we used to take call. Now we have a dedicated group of 5 on-call coordinators. This is what happens when we find a donor for our recipients. So how do you determine, so when a recipient gets a phone call that there's a donor for them, at that point, we've been working on that specific donor for hours, okay? So we've discussed it with our pulmonologist, with our surgeon in the middle of the night. We've gone back and forth with the organ procurement agency about all the things we request sometimes. The donors are screened for their medical information, including their social history. And we look at their blood gases the same way we evaluate a recipient, same way we evaluate a donor. How the donor died, age, height, weight. medical history of the donor, social history, the blood gases. You guys, I'm sure, have had arterial blood gases done before, right? We do that on the donors, usually every 2 to 4 hours. We look at their CAT scan. They perform a bronchoscopy on the donor, so you can imagine this donor has been declared brain dead. The family has consented for donation, so they would do there's standard procedures of what's done to determine how the quality of the donor. Like I said, CAT scan, bronchoscopies, serial blood gases. We look to see what's been growing. When they do a bronchoscopy, they suction out some fluid from the lungs and send it to pathology to see what's growing. We want to know that there's no virus there or bacteria. Bacteria is treatable. That's why you have antibiotics. Okay. So these are things that we discuss with our surgeons and our pulmonologists on the quality of the donor. And then once we accept that, and that's when the phone call goes to the recipient. So when we call the recipient, in terms of the donor team, what happens is when the recipient goes into the hospital, our hospital, they get pre-op. And while they're getting pre-op, we send our donor team out to the donor hospital. It may be local, it may be out of state. We've gone far east as Tennessee for a single lung, and we've gone far out to Hawaii for a double lung. So, and then we coordinate all this, so by the time when our team gets to the donor hospital, now you can imagine most donors usually would donate heart. If it's a healthy donor of heart, lungs, kidney, liver, pancreas. So you can see there's a lot of these procurement teams, that's what they call it. The procurement teams landed at donor hospital. Maybe there's 4 or 5 of them, different ones, from all different facilities. They all get there, they wheel the donor to the operating room, and they operate on the donor. You have a team, the abdominal team, that's usually 2 of them operating on the abdominal part, and you have the cardiothoracic surgeons operating for the heart and lung team. So you can see it's a group of people that's there operating on the donor. And then when we visualize the organs that we're there for, the lungs, usually that's the final inspection that we do on the donor. We also do a bronchoscopy, even though the bronchoscopy was done previously. We want to make sure that what they're telling us is what it's there. It's like selling a car, or car salesman. So you want to verify what they're telling you is what it is, right? So our team will do a bronchoscopy, cut the chest open. They usually will do a sternotomy on the donor, visually inspect the lungs that we're going to take. Now that's when we'll know whether or not the surgery will happen. So the team usually will call over to where the recipient is, saying the visual is good. Then the team with the recipient will then wheel the recipient into the operating room, put the recipient to sleep, and start working on the recipient. Okay, so we coordinate all this. By the time the old lungs are ready to be explanted, the team walks in with the new lungs in the cooler. Okay. Yes, Kurt?
Jay, how do you sort that out nationally? I mean, every hospital wants lungs, so is there a national list? Who determines that you get the call and not a hospital in Chicago?
Very good question, Kurt. So usually wherever the donor is, okay, there's been a new policy now that where the donor is, that organ is offered within a 250-mile radius because of the lawsuit that came about a year ago in New York and New Jersey. Because a lot of people in New York were getting transplanted who are a lot less sicker than people in New Jersey because of the different organ procurement. So because of that lawsuit, they changed it to 250-mile radius. So does that answer your question?
Yeah, but you said you got lungs from Hawaii.
Yes, rare blood type. So when you have a rare blood type, most often than not, there's not too many on the list. Yeah. Yes?
What social factors do you use in determining qualifications?
For recipient or donor?
Both.
Recipient, you have to make sure that they have a support system. If we have a recipient that walks in through our door have no family, no friends, they live by themselves, unfortunately, we cannot offer a transplant. Because it takes a village, and I'll show you why. Because the person will need somebody to drive them to clinic, make sure they have financial, to pay for medication, and also support system, make sure they're taking the right medication. So we've done it in the past where recipients had limited social support, and they never turn out well at the end. Okay, yes?
What's your window of time when you take a set of lungs out of someone that they're viable before you put them in someone else?
Usually about 8 hours, it all depends. So that's why we time everything. So by the time, so going back to this, so what happens is when we say the visual is good, and that's when our team, what we call cross clamp. Cross clamp is a term we use when we cut the blood flow to the donor. The minute we cut a blood flow to the donor, we then immediately flush it with a cold solution. And that's meant to shock the donor's lungs to slow down the metabolism. We then pack it in the cooler next to our soda. But yeah, that's what we call cross clamp. So we actually count the amount of minutes from the cross clamp to the time we rewarm the organ. So there's cold ischemic time, and then there's warm ischemic time. So, and that goes into the operative note to see how long, because we use that as for quality assurance, performance improvement. And that also is related to the quality or the recipient's progress. See, the shorter the time is, the better it is usually. Okay. Dry run. Oh, I'm sorry. Yes.
What is it that you would consider end-stage?
End-stage lung disease?
Yes.
It's
to be qualified.
usually if your pulmonary function numbers are below a certain number, depending on what your diagnosis is.
And what would that be?
Depending on what your diagnosis, usually fibrosis. If somebody has fibrosis, they get referred right away because it's such an unpredictable disease. For COPD, it's usually, we'd like for them to be referred once their FEV1 is below 30%.
The FEV1?
FEV1, yes. That's one of the lung numbers that you look at. Yes, back there.
Aside from smoking, what would be some of the social aspects of the lifestyle you'd be looking at for the donor?
Oh, for the donor? That's a good question. You know, when going back to the donor, 1 out of 3, 1 out of 4 donors are labeled increased risk. So this may go over your head, but I'll explain it. 1 out of 3, 1 out of 4. Okay, 25 to 33% of donors are labeled increased risk. What does that mean? Increased risk means this donor fits a certain social criteria, which means some of them may have spent time in jail or prison, okay? The rule of thumb is usually if somebody spent time in jail, even one day, okay, 12 months before they became a donor. Let me give you an example. If you had an 18-year-old got caught drunk driving 11 months ago, and then one day across the street got hit by a car, became a donor. That donor is labeled increased risk. Doesn't that sound scary? So, but remember, every donor who's tested, they're tested for HIV and Hep C. Okay, that's particularly what the PHS is concerned about, is the increased risk donor. But that's one of the social criteria we use to determine the quality of the donor. But as a program, we recommend for recipients to say, yes, I'm willing to take an increased risk. Because as a program, we vet out every donor to make sure that the increased risk of transmission is low. There's never a zero risk. Okay? Yes?
Why would somebody that's been in prison in the last 12 months be, a risk, a higher risk?
Because transmission for HIV and hepatitis C. But again, every donor's tested, okay, and they're all negative. One comment about there's never a zero risk. Let me give you an example. If a donor exposed himself to a high-risk behavior, okay, and got exposed to HIV, 2 days before he got in an accident and became a donor. If that donor was checked for HIV, he would not be positive. It takes 2 weeks for your blood stream to convert. So therein lies never a zero risk. Yes?
What if somebody is a carrier of one of them but doesn't actually have the disease? If they become a donor or if they want to become the recipient?
So there's never a carrier for that. You're either not or not, is or not.
Really, because I've been diagnosed that I have the hepatitis C, but I've never had the disease in 25 years.
Yeah, well, yeah, I don't know what that is. There's usually...
I was exposed to hepatitis C and built up an antibody to it.
Okay.
I'm basically a carrier and...
But your viral load's probably zero.
Exactly.
Yeah. Yeah, so for that case, now hepatitis C is curable. So actually even HIV is not curable, but it's treatable. So these are things that we look at as a program. But we don't use donors who are HIV or Hep C positive, bottom line, okay? Anyway, going back to this, any other questions? Okay, I'll go ahead and finish up. Dry run. Dry run is when our team is actually in the facility visualizing the donor lungs and realizes these are not good lungs. Okay, and I'll show you. These right here are chest x-rays of beautiful, healthy double lung. CAT scan. This is what they look like when they do a bronchoscopy, where they stick a scope in the lungs. That's what we want to look at. We don't want to see any pieces of rice or pieces of shard glass. Those are we've experienced those, where broken glass from a windshield. And next, beautiful set of lungs. Okay. They look like tofu, don't they? These are beautiful set of lungs. You can tell this donor did not grow up in Los Angeles. If it did, it'll have black streaks running out. Yeah, you know when you were a kid, when you used to run around, you have black streaks on your neck because you've been playing. That's what it would look like. Next one is a picture of a bad set of lungs. These are lungs that we took from a donor. They look okay when we put them in the bag, but when we came back to our hospital, opened it up, it was hemorrhagic, so we didn't use them. That's what those bad lungs look like. This is our team. We have 2 helipads on top of the UCLA. This is Dr. Benwali. She's one of our very gifted surgeons. She does heart and pediatric lungs. I mean, pediatric hearts. So you can imagine pediatric hearts. They have to open up these tiny holes and replace a heart. So she's a very, very gifted surgeon. Okay, surgery. We do a double lung will be a clamshell incision, just like this, right in the far right. And bilateral thoracotomies, that's 2 incisions. For example, if a recipient has some unusual body habitus, somebody, usually if women have large breasts, those are can be a curse because we can't do the clamshell incision. We have to do it this on the side, and then single lung. Again, it goes around you, whichever lung we transplant on you. How the rib curves around on the side, just like this picture here. Okay, sternotomy. It's rare we do sternotomy on a double lung. I would say probably, I don't remember we've had done one in the last 2-3 years. Women, sometimes if they have breast implants, unfortunately we have to have them be removed before, because we can't do the clamshell incision if they have implants. Because the implants with the sternal retractor, it gets crushed. Yes, Calvin? Okay, so because you had a bypass, right? Yeah.
I had a heart valve.
Yeah, a heart valve, okay. See, that was a special that month. You lucked out. And like I said, about the concomitant procedures, we're one of the few centers that will do the bypass, valve replacement, the PFO closure. Sometimes if you have a hole in your heart, we close that too. And these procedures are if you have atrial fibrillation.
Jay,
Yes?
curious question. Back to the lungs. Is there any way, if you have a transplant, can you get a picture of what was in you?
That's a good question. You're going to have to request that. We haven't had anybody request that at UCLA. I know at USC we would do that when we did usually do living lobar. We'd actually take pictures of the old and new lungs.
What if they wanted to have a
I think you're going to have to bribe the pathology department for that. Recovery, average stay is about 14 days. Half of that in the ICU, half of that on the regular floor. It's all private rooms at UCLA. We talked to you about your basic common sense precautions after transplant. Remember, you're going to be immune suppressed. Okay, your immune system's not going to be what it is before the transplant. So you're going to be a high likelihood of getting any infection. If somebody's sick, outright sick, you tell them, don't come near me. Hand washing, very common. You need to do that. Lifestyle changes. If you like sashimi, forget about it. Okay, I love sashimi. I hope I never have to have a transplant. The pharmacist would do medication teaching. You're going to be in a whole new different medications. Okay, and then one thing we tell people: no grapefruit because it affects the medications. The far right there, that's a graph on one of the tacrolimus medications we use for anti-rejection. Basically, most of the medication we have you take it every 12 hours. And what that happens is for the tacrolimus on the far right, that's a main transplant medication we use. What happens is after you take it, 3 hours later, it hits a peak in your bloodstream. And the next 9 hours, it trends down. And then just before the 12-hour dose, you do take the next dose. The goal for that is to keep a therapeutic bloodstream level in your bloodstream. I'm sorry, forever, yes. Anti-rejection medication is a group of 3 medications: prednisone, tacrolimus, mycophenolate. You take that forever. Okay? Yeah, mycophenolate is a cell step. Clinic, we do once a week for about the first month, and then it tapers down to every 2-3 weeks. The clinic consists of x-ray, blood work, and we have you do the breathing test. Usually the breathing test will be at the second clinic appointment. You see the pulmonologist, and then you're going to become good friends with your pulmonologist and your coordinator. Kelvin, who's your coordinator? Leslie? Okay. So you're going to be good friends with them, okay? They're going to be your lifeline. Who's that? Wayne. And Wayne, yeah. So those guys are going to be your lifeline. And we do surveillance bronchoscopy, okay, to rule out infection or rejection. 1 week, 1 month, 3 months, 6 months, and 1 year. And that's we do that. We'll give you a conscious sedation. We'll stick a scope down your lungs, take a piece of the lung, send it to pathology, and then the day later we see whether or not you've had any rejection or infection. Because sometimes rejection can be, you can have no symptoms. Okay. Issues and challenges before transplant. Finding donors for shorter recipients. If we have a recipient that's 5 feet tall, it's so difficult. Even though they have the highest score, what happens is, if you, more than likely, shorter donors are pediatric patients. So what happens is, they are offered first to pediatric recipients. If there are not any recipients there, then it's offered to adults. Yes?
What in the pathology slide would you see that would indicate to you rejection of the lung?
Well, that's the pathologist question. There's certain criteria that they look at to determine whether or not there's rejection or infection. And I wouldn't be able to tell you because those things are over my head. But it is we have certain dedicated pathologists that read those rejection. Okay. Sensitized patients, that's what I talked about when you have antibodies in your bloodstream that doesn't help you, it shrinks your donor pool. ECMO related, has anybody heard of ECMO?
Yeah.
Yes, okay. So ECMO is like the Hail Mary pass. It's the last hurrah to try to save a patient's life. I thought I put a picture on there, I guess not. So an ECMO, extracorporeal membranous oxygenation, it's an artificial lung basically. So they put a big, almost garden hose size hose on you. That takes out your venous blood. It goes to this machine, it gives it oxygen and shoves it back in you. Okay? So there's two ways about it. They can either give you a centralized ECMO where you can't walk, but for being a lung transplant candidate, we try to give you a peripheral ECMO where you can ambulate. But when you ambulate, there's 6 people around you. Okay, you got somebody with your portable chair behind you. The machine's being pulled. I mean, it takes a village to walk somebody. I think there's pictures of YouTube, videos in the YouTube of patients on the transplant list being walked in the ICU, and there's 6 people around that. Okay, so it takes a village, especially when somebody is on ECMO. I think we looked at last year's numbers. We had 10 patients while on ECMO before they were transplanted, which means they were sick as a dog. They are the sickest of the sick. Okay, and we're one of the few facilities that have been fortunate enough to be able to guide them to have a transplant. Actually, we had a lady from Texas who came over in March because nobody in Texas would touch her. She was on ECMO, we flew her here. She had some antibodies that I mentioned that was so difficult, and we were fortunate enough to transplant her, and I think she'd been out of the hospital for about 3 weeks, so far so good. So we have such a bleeding heart, we'll, you know.
For those of you that know Roy was on ECMO before he got his transplant.
Roy Arnold. Yes. Another issue we have is the lack of beds. UCLA is so full all the time, it is crazy full. I get an email every day that's a red high census alert and nobody can come in from another hospital. So it's very difficult. Being AB donors, the longer wait because there's not too many out there, okay? So these are the issues and challenges we have pre. And on the post, consistent follow-up with the coordinators and the pulmonologists. Sometimes when patients do so well, they forget they were even sick. So they're like, oh, I'm gonna cancel my appointment. Yeah. Next one is insurance issues. Co-pays, loss of insurance or change. So we've had a few patients where they change their insurance to Medi-Cal and they can't be followed up with us. So they have to go to USC, unfortunately. Moving out of the area. My personal opinion, if people move out of their area where they're close to the transplant program, it affects their survival. It really does. We had somebody move to Buffalo, New York. Like, oh my God, why? Why Buffalo? Yeah, so those are the things that but sometimes people can't help it. You know, they have to move to where they have support. Loss of support network, a divorce, loss of income, loss of a job. We've had patients upgrade or downgrade their spouse. With all the medications you're on, a lot of people suffer depression, substance abuse sometimes. So these are things that we deal with. You know, it's not like we can take the lungs back and you know, so we have to work with these issues. I mean, we all have issues, right? Other complications for post-transplant. Chronic rejection is the biggest killer. Okay, chronic rejection, basically, no matter what medications we give you, your immune system fights through that and attacks the organ that's in there. Kidney failure, that's why we do creatinine levels every time we see patients to make sure it's a balancing act what we do with the medications in your lab numbers. Okay, increased risk of cancer. That's a very big thing that we're encountering now. When we do a single lung transplant, the native lung that we leave there, sometimes we'll get cancer. Okay, so these are the big things that we're dealing with. Even though we do a double lung on somebody. One of the things that's very hard to do is differentiate cancer from pulmonary fibrosis. If you do a CAT scan, and sometimes it's very hard to differentiate. We've had a few instances where we took out the old lungs from a healthy, from a 45-year-old recipient, okay, 45. Took out the lungs, had a successful surgery. We look at the lungs in the pathology, it's got cancer. So these are rare things, but they happen. Viral infections, one of the problems also that we're running into post-transplant, okay? So it's very difficult when somebody gets a viral infection after transplant. A lot of times it attacks the lungs and you lose lung function. Okay, you lose lung function to the point sometimes they may need a redo transplant. So it's very rare, but it does happen. So these are the complications we deal with as a program. It takes a village. These are the team that we work with. You can imagine actually it takes a village to not raise a child, but to keep a transplant patient alive and have them not regret the procedure. This is our team, including the OR, everybody and their mothers there. And we do a Donate Life walk. As part of Donate Life is in April at Cal State Fullerton. This is One Legacy runs this. It's a way to honor the donor family. So the donor, each donor will have their own pop-up tent there. The donor family would be there. And oftentimes we encourage our recipient to write a letter to the donor family and to say thank you. Because without them, we would not be doing this. And it's a very, I don't know, it's a tearjerker when you see there, because each one of their donors, the pictures are up there, a description of them, from pediatric donors to older donors. It's a very special moment, and we do this just to honor the donor family. These are my cartoons. In and out lung transplant. Your heart's in great shape, but I'd recommend transplanting all of your other body parts. This one, doctor, I don't think the 5-second rule applies to transplant organs. Thank you very much. Any other questions?
If you have any more questions, you can follow up with Jay individually. Let's give Jay another round of applause for a great presentation. Don't forget the PEP fundraiser. You can get envelopes from Ann right here. And we'll see you at the next luncheon. And remember, we gotta reach our goal, you guys. We gotta reach our goal. Thanks, everybody. Drive home safely.
Okay. Okay. Well, that's what happens if you have cancer. You have to be